I'm going to give sort of an overview about what we're trying to do now as far as injury prevention goes. Dr. Micheli, who quite honestly has achieved so much in the field of sports medicine, could probably sit back on his laurels these days and enjoy what he's done. But as opposed to that, several years ago, he looked at the original charter that was written for our division. And it said that we were going to find better ways to diagnose and treat sports injuries, and it said we were going to find ways and better ways to prevent sports injuries. And he felt like, we had been trying to prevent re-injury. So if you were a patient, you came to our clinic with an injury, we tried to prevent you from getting injured again. We did some research, gave some lectures about preventing injuries overall, as you had seen. But he felt like we really weren't doing enough. And so this is before I was even a part of the division, the entire division got together and said, how can we focus on this as a new sort of branch of study? And they set about to raise money to develop the Micheli Center for Sports Injury Prevention. And I'm going to talk a little bit about how it works. They raised almost $2 million to construct it, buy all the equipment, and get the initial staffing for it. And it's dedicated to two things. It is a sports injury prevention research center, of which there are a few already in existence. And Dr. Engebretson is going to talk about that and is clearly one of the leaders in that area. But also a place where an athlete could come and learn what they're at risk for and what steps they can take to reduce their personal risk of injury. So a service that's provided directly to the athlete. He called a big meeting shortly after I had joined the division, and we filled the room with all of our clinical staff, the athletic trainers, physicians, nurses, everybody who works for our staff, and he gave us all assignments. He gave us either an injury or a sport for us to research. And if you had a sport, he said, okay, you're going to review all of the medical literature, all of the scientific literature about that sport, and find out what are the demands of the sport. What are the most common injuries in that sport? What are the risk factors for those injuries? And what evidence is out there already that says you could change those risk factors and decrease your risk of injuries? And we did that, and we put together a manual. We then raised the money and started constructing the building. And of course, it would be very difficult for the people working in the building to just memorize the manual, right? I mean, there's all these variables associated with sports injury. It's different per sport, per gender, per age, per injury history, what injuries you've already suffered. And so we did two things. We hired a full-time computer programmer, Felix Wang, who wrote us our own personal software. And I'll show you some of the screenshots when I explain how it works now. And then we hired Emily Hansen, who was an athletic trainer, to take the data that was in the manual, supplement it with newer research that was still coming out, and put it into the software that Felix had designed so that the computer system would identify any measurement that was a risk factor, put that injury on their prescription, and show them how to do it. And I'll go through in a minute how it actually works. And we opened just in April of this past year. The way it works if you're an athlete is you come to the center and you first sit down at a computer. You give us some basic information, how old you are, what sports you play, what sports injuries you've had in the past, and then other variables that are associated with injury. How many hours a week you train, how many hours a night you sleep, a little bit of information about your diet, etc. And then you move out to the floor, and when you're on the floor, our injury prevention specialists measure 300 variables, a little over 300, it's like 317 variables that are associated with sports injuries. They measure your bony angles, the range of motion at your joints, strength in opposing muscle groups, your flexibility, speed, agility, power, everything that somewhere in the literature has been associated with a sports injury. It takes about 3 hours, 3.5, depending on how many sports you're participating in for the full evaluation. You then meet with an MD who has in front of them the list of injuries you're at highest risk for and steps you can take to reduce your risk of injury. The MD then performs a physical examination dedicated to the parts of the body that you're at highest risk of injuring and goes through the prescription. And so when you leave, you get a packet, sometimes a fairly substantial packet, that lists the injuries you're at highest risk for and the steps you can take to reduce your risk of injury. Some of the steps are quite easy. Some of them make this adjustment to your training regimen or this adjustment to your sleep schedule. Consider this type of equipment. Some of them demand more of the athlete. They are, you need to improve your strength in the following muscle group or improve your range of motion in the following areas. And they take it with them. They can do three things with that packet, right? So the easy steps, they can just adjust and they're done, right? The more complicated ones, they can come back to the center to work on them. They can take it to a gym or a YMCA near their home and work on it there. They could take it to their strength and conditioning coach or their personal trainer or whoever else they work with and do it there. And every 3 months, they can come back and get reassessed. See, have they improved on those measures? Have they reduced their risk of certain injuries? And where can they go from there? That's the way it works. We have partnered already with many of the physical therapy groups in the area, with the local YMCAs of New England. In fact, every YMCA in New England now, if you show up with the Micheli Center packet, not only can you get some instruction and proper technique recommendations, but they give your whole family a membership for $12 a month. So we've really tried to strengthen our partnerships and allow athletes to do this everywhere. This is the software system. So the way it works is the beginning, they give us some information on computer. Anytime they punch a variable in that increases the risk of a certain injury, their prescription gets populated with that injury. When they're out on the floor with our injury prevention specialists, if they enter a number that is associated with an increased risk of an injury, again, the computer program automatically pulls that injury onto their list. And when you have an injury pulled onto your list, what comes with it are steps you can take to reduce your risk of that injury and change that risk factor, that variable. This is designed just for us. This is some screenshots of our overall system. And you can track their progress. So Felix Wang is a computer programmer. He's not a clinician. And so he initially showed this graph as Q angle measurements over time. And the Q angle doesn't change like that over time, so I had to put a gray bar across the top of it. But you get the idea. You can track progress that the athletes are making. There are also other services. So maybe there aren't people playing many sports who want to know their overall injury risk profile. Maybe they just want to focus on a few things. Guys my age now who tend not to participate so much in team sports, but do a lot of road races or cycling or triathlons, they might just want to come in and say, look, I battled with plantar fasciitis over the years. I had some iliotibial band. I just want to reduce my risk. We have a dedicated running program run by Pierre Demicourt, who is the head of the primary care sports medicine group and also one of the medical directors for the Boston Marathon. And athletes will get up on a treadmill that has a force plate underneath. So it will measure the impact forces of the foot as they run. There are video cameras from the side and from the back that will allow the specialists to see, are they heel strikers, are they midfoot strikers, forefoot strikers, do they overpronate, do they drop their pelvis as they run, all these variables that are associated with their risk of running injuries. And then if they identify variables, they can undergo gait retraining, where they get some advice and videotapes and work with a specialist on changing their gait to reduce those risk factors. There is an ACL prevention class. Many athletes say, look, my sister tore ACL, or I tore an ACL, I don't want to tear the other one, or tear my graft, and they want to know what they can do to reduce their risk. Now, we have a lot of doctors that specialize in ACL management, but certainly Doctors Kramer, Murray, Coker, Hayworth, right, Micheli, I mean, I guess most of them know about this, research this, and we have developed a class where athletes can work on changing their risk factors for ACL tear to decrease their risk. We have lectures and classes for the community, for coaches, for parents, for physicians who are not already involved in sports medicine. Dr. Stracolini runs what's called the Active Kids program, which does two things. Really, it encourages exercise among all children. It turns out that if you are previously sedentary at a young age and you then enter sports at a later age, developmentally you sort of miss the time period to develop the neuromuscular control that's required for athletics. And so your risk of injury is higher. And working with our collaborators at Cincinnati Children's, Dr. Greg Meyer, who's here, you're going to hear from later today, we've developed a program where you can engage them in neuromuscular training to try and decrease their risk of getting injured in the future. Dr. Micheli, Ruth Solomon, Mickey Casella, Heather Southwick, a lot of people involved with dance injuries for years and years now, helped us develop our dance program. Dancers who are at high risk for different injuries than non-dancing athletes can come in and get assessed and undergo a dance injury prevention. We have a force-absorbing dance floor, a mirror with a ballet bar, and we can try to reduce the risk of injuries in dance. And finally, we also do one-on-one training sessions for people who want to carry out their prescriptions at the center. Lastly, you can imagine insurance companies do not pay for this at present, right? It's prevention unless you prove that you will prevent enough injuries that the cost of paying for the prevention outweighs the cost of the treatment. They won't cover it. And so what happens instinctively is that there's a lot of children of wealthy people coming in to get this and a lot of poor athletes who can't. And so right off the chute, we started a scholarship fund. So far, we have $40,000 of donations so that we can help kids who can't afford this come in and get it for free. We even arrange for transportation. Sometimes we do coordinate with some of the schools in Roxbury and bring the kids out there for it. So that is our services. We just opened sort of middle of April, and these are the numbers so far. Started out relatively slowly and then just had a massive increase. And the bottom line there is the total number of visits by month. August was 253. We're right on track for doing that, or perhaps a little bit better than that in September. And so far we've had 571 athletes come to the center for one of our services. Research, we started right away. As always, when you engage in a major project like this, it takes longer than you think. And we had already hired staff, and as far as working with the hospital and pulling permits and getting the construction going, it took longer. So we used existing databases, some of the things that Dr. Stein was talking about that are put out by the CDC. And the way we're going to go about approaching the research is first, what I call immediate research, using existing databases to determine risk factors for injury, prevalence of certain injuries, etc. There is not a lot of normative data. If you want to know what is the quad to ham strength ratio of most 9 to 12-year-old soccer players, it doesn't exist, right? And so initially, just finding out what is the normative data is, I think, a good starting place for a lot of this. And finally, when they come in, they tell us injuries they have already sustained in sports, and then we measure all of these biomechanical factors on them. And I suspect that right away we will be able to tell differences in the biomechanics of injured athletes versus uninjured athletes, called a retrospective case control study, to try and identify new variables that we yet don't know about. That would be the immediate research objectives. The intermediate, of course, is they are leaving the Micheli Center with a prescription of steps they can take to reduce their risk of injury. So number one, are they compliant with it? Do they fulfill the prescription? Is it too much, or is it just enough, or do we need to tailor it? And if they do they change their risk factors? In other words, if we tell them you're going to focus on strengthening your hamstring muscles, do they do it? When they come back for their 3 months assessment, has it worked? Are they stronger? And finally, my favorite part, which is really the long-term research, we have applied to the IRB so that every 3 months we can email or text, or however they want to get it, just a handful of questions to these athletes. Number one, they get a copy of their prescription. They put a check in a box next to every component of their prescription that they have fulfilled twice a week or more since their visit. An idea of have they done the exercises, right? Number two, they're asked, have you been injured playing sports in the last 3 months? The other questions are a little bit about how many practices they've had per week, etc. If they've been injured, we ask to contact them to get details about the injury. What was it? How did it occur? Etc. And the goal, of course, is now we have 317 variables on these athletes. We want to identify as they go forward what was the difference between the ones that tore their ACL and the ones that didn't. The ones that got a concussion, the ones that didn't, right? To try and identify new variables that, as of now, are perceived or believed variables, but yet unproven. We started right away. This is just a list of some of the physicians and athletic trainers and other folks who work at the center who put stuff out already. The last one, perhaps one of my more favorite ones, exercise deficit disorder. It turns out that Dr. Meyer and Straccolini, both of whom I mentioned before, have brought a clear point to our eyes, right? If you have high cholesterol, it is not at present doing you any, you have no symptoms from it, no signs from it, and yet we treat it. We recognize it as a risk factor for stroke, as a risk factor for heart attack, and we treat it, right? Obesity, and even less than obesity, just exercise deficit, is a risk factor for disease in the long run, right? People who exercise are at lower risk for stroke, for heart attack, for high blood pressure, for high cholesterol, right? Things that increase your risk of those things, and we treat it. It turns out there is a code. There is a sort of, what do you call it, ICD-9 code, right, for exercise counseling. If you identify an athlete and you say, or a patient and you say they are not getting enough exercise to keep them healthy and to prevent them from getting problems in the long run, there's a code. But in the last 5 years at Boston Children's Hospital, where we've cared for, millions of patients, right, how many times do you think that code has been used? 14. Dr. Straccolini told me last night, 14 times, right? So clearly it's underutilized, and they really have more of an advocacy agenda saying, what are we doing here? This is already existing data, and we're all just ignoring it. I'm going to try and speed through. I just want to focus on one particular topic. I think the people in this room understand the importance of sports injuries, the effect that a sports injury can have on an athlete's life, on their long-term health. A lot of people don't. And if you are competing for attention, if you are applying to the NIH for a grant, and you're studying cancer or AIDS or something like that, I think that they're going to be much more sympathetic than if you say you're studying sports injuries, right? Now, most of them probably were not athletes, right? And so they don't understand what we in this room know. And so I said, well, look, how can I get their attention? And life-threatening injuries are relatively rare, right? In life and in sports. But if you think about children, they don't do a lot of high-risk activities for life-threatening injuries, right? They're not working up on skyscrapers or driving too fast on the highway intoxicated, right? And so we had this hypothesis that even though life-threatening injuries are rare in sports, I bet you of all the life-threatening injuries occurring in children, a substantial proportion occur during athletics, right? It's like the one thing they do that's mildly risky. And I thought maybe it would be 10% or 15%, and that would be enough to get their attention. So we used an existing database put out by the CDC of emergency department visits in the United States. And we defined life-threatening injuries as it had previously been defined in other studies. Direct trauma to the brain, intracranial hemorrhages, cervical spinal fractures, splenic rupture, aortic rupture, clearly life-threatening injuries. And it turned out that for children, 6 to 18 years old, right? So we didn't look at 0 to 5 because most of them are not engaged in organized sports. And 18 and over, we figure that's sort of an adult. It turns out that nearly 40%, so 39%, it's the number in the parentheses there, of life-threatening injuries occur during sports, right? So there's not a lot of life-threatening injuries in sports, but there's not a lot anywhere, and the proportion that occurs during sports is 39%, fairly significant. Lastly, these are other minor things that, not even minor, but things that we've pointed out in addition. It turns out that of athletes coming to clinic, 30% have sustained a concussion previously that went undiagnosed. And of course, the reason that's important is if it's undiagnosed and you go back to sport, little minor blows to the head that typically won't bother you will prolong your symptoms, increase your risk of long-term effects, and of course, is a prerequisite for second impact syndrome, which in this room, I think most people know, is a devastating injury, right? It either kills you or you are for life neurologically devastated. We also discovered that older children suffer from a higher proportion of overuse injuries. So if you're trying to prevent injuries, you need to know where are they occurring, right? If you're trying to prevent overuse injuries in young kids, they're not getting them anyway. That's really not a lot of bang for your buck. You need to focus on the older children. We looked at bicycle helmet laws. So cycling is becoming more and more popular for athletics, even for commuting and everything else. Just in general, cycling is becoming more popular. But certainly more children are bicycling, and it's a great way for them to get exercise. Nobody debates that if a child or any athlete, for that matter, is wearing a helmet, they're less likely to have a problem. But you'd be surprised the people who debate whether or not the laws mandating the use of a bicycle helmet are helpful. There are big debates about this, many suggesting that the laws are actually harmful. The bicycle unions are totally against this because they think less people will ride if they have to wear a helmet, right? Which I don't think. But so we separated states in the United States into those that had a law mandating that cyclists, pediatric cyclists, wear a helmet, and those that didn't mandate it, and found out that the risk of dying in a bicycle motor vehicle collision is 20% less in states that mandate a law, right? Makes sense, right? Of course it's going to be less. I don't even know why we had to do that, but we did. It turns out that also incapacitating injuries were reduced by about 20%. We took it out because of a reviewer. And then lastly, I sort of jumped ahead and talked about exercise deficit disorder, but that I think is a major push that we need to lead. We need to lead that. So I'm going to try and end. I'll just put the mission statement up. No one will be able to read it, but if it's up there while Bethel and Dr. Coker are getting ready for the next speaker, maybe you can get a glimpse of what we do. Thanks for listening.